I'd like to begin by handing over to the IEPA President, Professor Mizuno, to welcome you to this Satellite Symposium and to give an introductory address. Professor Mizuno.
Good evening, and welcome everyone. Buonasera tutti. I deeply appreciate your participation. But first of all, I would like to tell our sincere thanks to the Oscar Europe and Lundbeck for your great sponsorship for this symposium. Oh, yes. Also, in the last conference in Tokyo 2 years ago, we could have a very fruitful discussion, and its content had been published as a paper in Early Intervention in Psychiatry journal. We have seen enormous breakthroughs, so many areas of early intervention in mental health, which has gained the proof of concept and understanding by professionals in these 2 decades. However, we have to honestly confess the reality of the limited spread of the implementation of early intervention in the community. Besides the UK, United Kingdom, and Denmark, and some parts of Australia and Canada, strategic intervention for young people and people in the earlier stages of mental disorder is not so common and remains very spotty. We are continuously heading into a critical period that will be testing the empowerment for the implementation of early intervention in the real world. So we should address the most fundamental and classic issues of psychiatry services, including social and internal stigma, lack of mental health literacy, and limited health budget, and also translating policy and so on. Understanding the variety of transcultural background and new concepts on mental health is very useful for policy making and planning a new design for community mental health. So looking back and now moving forward. Recently, the United Nations released the projection of global population growth over the coming century. In the year 2100, the world's demographics will look very different from today's. So have a look. Here is the life expectancy at this year, and will be changed in 2050. And also, this is the total fertility median projection in these years. So the world is aging progressively. The latest prediction for population growth from the United Nations indicate the Earth will be more crowded than previously thought. So the global population is currently about 7.3 billion. The United Nations estimates that by 2050, the number will grow to 9.7 billion. By 2100, 11.2 billion people have come together on the Earth's surface. So the biggest increase in population will happen in Africa, with Asia in second. So health systems in these countries are poorly prepared to address mental health needs, with insufficient development of the most fundamental of health system resources and social supports. So the argument for investing in development of early intervention service goes beyond health alone. It can help protect the most important asset, that is the educational capital and human capital in any countries. I hope this symposium will become suggestive for those looking to develop new strategies today and to strengthen mental health service tomorrow. I deeply appreciate all of your participation. Thank you very much.
May I have the next slide, please? And the next one. Right, I'm now going to talk about, introduce the difference between clinical intervention and system implementation, and just reflect on what has happened over the past 15 years in England and what is happening at the moment. These are my disclosures. I get paid by the University of Cambridge and the NHS. So, what has happened in the past? So we had a plan, the National Health Service plan, in the year 2000. I was very struck listening to Bob Heinsohn this morning talking about the implementation of early intervention services in North America with the RAISE program. And it struck me that we've got an international new model. So it was as though the Australians put the first human on the moon, and then some European people put more humans on the moon. England sent quite a few rockets to the moon, whereas in the last 4 years, the Americans have now built a space station on Mars. So it is possible for this to move very, very quickly, but it's worth reflecting on what the good parts of that are and what the unintended consequences might be. The English health policy in 2001 was it was codified in 2000, a year later, by the Policy Implementation Guide. And that caused the rapid increase in implementation of early intervention services in England. Come 2008, when we had the global crash, many public services in England and across Europe came under terrific financial strain, and the value of early intervention services was in jeopardy. Managers who had to save money valued the services less, even though it's part of a mental health evidence base that, of course, we know there's very good evidence for clinical and cost effectiveness for early intervention. So there's been a new way to increase the funding for English early intervention services, and it's used a new policy implementation model, a new, if you like, model of implementation science. What happened was that early intervention services copied cancer and other physical health services in having a waiting time target, something that's been very effective in changing physical health services, as I mentioned, particularly for cancer services, where, just as in psychosis, there was a long delay between first evolution of the illness, patients recognizing that they may have a problem, and receiving effective services. So we have a new policy from April 2016, this year, which is about an access and waiting time target and standard. So like cancer services, early intervention services in England now have to try and see they have to allocate a care coordinator to any person who is referred to an early intervention service within 2 weeks. So it's a very ambitious target. But the standard is that has to be achieved at the moment in only 50% of cases. So the waiting time target is a 2-week one. The standard is 50%. You might think that's really rather low. But in fact, it's been tightened by the fact that a service can only meet that target and standard if it delivers a full range of services, which comes back to fidelity, which we were talking about in a session earlier today. So there's a very strong leverage being put on early intervention services re-implementation. We're in our second phase of implementation in England, and it's, as ever, it's interesting times that we're living in. Now, 2 years ago, Professor Mizuno mentioned that there was a similar seminar 2 years ago where we were taking a rather narrow view of what could be done rather than this service implementation science view of trying to implementing systems. And I showed some slides of some work by James Kirkbride and others, including myself, developing a population prediction tool for psychosis, where we could take a map of the country and break it down into small areas and predict how many cases of first episode psychosis there would be. And here's a map of England showing a colour code for red is very high incidence areas and green is very low. And our first policy back in 2000/2001, the assumption was that everyone had the same need, population need. But now we acknowledge that if you live in an inner city area, then Birmingham, for instance, then you might have, of course it's missed off here, but about 250 new cases per year. Whereas if you live in a rural area, such as this one, Craven, you've got 5 cases a year. So the point I want to make from this is twofold. One, we are using tools like this, and there are others, to target funding in our new access and waiting time target and standard. But in terms of the system, in our country, and I'm sure in all countries, we don't have a single system. It's actually highly stratified. And what's right for an inner city might be really wrong for a dispersed rural population. So widespread system implementation is good to get things going, but it has to be allowed to have nuance and to reflect the sophistication and stratification in different areas of, this is England, and I'm sure it's the case in other countries. So just to conclude on those reflections of England being in its second wave of system implementation, that it can be done. So you can influence the system by whatever are the political and medical tools, or the tools of medical politics at the time. Ours at the moment are waiting time targets and standards. We can plan, and we can show that the system is stratified and needs different solutions for different parts of the country. But all this bureaucracy, running something centrally, it can result in increased bureaucracy. We're finding teams now are having to spend enormous amounts of time filling in the paperwork so that we can return it to the Department of Health to show that we're meeting the access and waiting time target and standard, rather than seeing young people with first episode psychosis. It also means inevitably that there's a lot of focus on first episode psychosis at the moment, with money being found by commissioners to support this policy. But we mustn't forget that it's not all about psychosis. Psychosis services should be leading an increase in standards for other areas of mental health. So we don't want psychosis to become siloed again, and we don't want other services to become starved because of it. So this is just some reflections on what's happening in England at the moment. Thank you very much.
I'm too short to climb up onto there. It's a challenge to follow Peter. What I want to do in the very brief time that I have is to make some very brief reflections on the development of early intervention services, particularly in Europe, and then really for you to think about how or why different systems have developed in different ways, and what can be learnt from the experience in different countries. So, for instance, the model we've just heard in England, which was very much driven by the development of a national strategy, a national policy, and a very strong, I would say, link between policymakers and practitioners and researchers in terms of developing white papers and developing economic analysis. Can that model apply in other places? And if not, what sort of models can apply? What has worked in different areas? There's my declarations of interest, etc. there. What we did, we reviewed the availability of services in a number of countries. We looked to see what are documented as the barriers and facilitators to the development of services. And also, actually, is there any correlation as such between the availability of economic evidence that there's a payoff, a return on investment associated with first episode services and their expansion and development. And we really also wanted to look and see what sort of innovative things are going on, to what sort of constitutes a service these days in different countries. So it was a very broad piece of work, and we relied a lot looking at websites and so forth to try and identify what's going on. And this summary slide won't surprise most of you in the audience at all, I'm sure, that we have an extremely varied, as Professor Mizuno was saying earlier, we have an extremely varied provision of early intervention services around the world. We've had, the Australians leading the way, the Europeans picking up the baton, the Americans, the Canadians, etc., the Hong Kongese, if that's the right word, doing the same thing as well. And you can point to a number of countries with different experiences that have actually developed significant capacity for the provision of early intervention services. You can talk about the UK or GB really, because we didn't look at Northern Ireland, so I'm not going to talk about Northern Ireland. But you can talk at Denmark. But Denmark had a very different experience in terms of developing its services compared to the UK. Very much driven, I would suggest, by the experience of the Opus project and the evaluation of that. And I would also suggest very good advocacy and campaigning by those involved with Opus as well to try and extend the programme. You can point to what's been going on in Canada, again, pointing perhaps as well to champions that have led, for instance, to the development of the services in Quebec based on experiences in Ontario. You've had people like Don Addington over in Alberta helping to strengthen and grow services. So there are different experiences that you see in different parts of the world, and so what can we learn from those? That's a key thing. Peter's mentioned as well this whole idea of systems. I think, as most of you are psychiatrists in this audience, you're thinking very much at the narrow clinical level, I would suggest, but systems are an enormously important thing. How do first episode psychosis fit within the mental health system, fit within the general health system, fit within the primary care and secondary care systems, and fit within the wider social support, social functioning systems that are so vital to people with living with psychosis or experiencing psychosis. I think it's also fair to say that what we found when analysing the detail of programmes is that you can identify a number of programmes that exist, but they mean, of course, different things in different places, but often actually they can be, there may be a number of staff that are supposed to be part of a team and they're simply not there. So you have a less than full capacity workforce, but that doesn't always show up. So actually understanding how systems function also is about understanding what are the gaps within existing team capacities, and also understanding what sort of pressures they may be under to deliver services to other client groups because of the limits in resources that may be available. Well, my time's running out. So one of the key points here is there are different take-home messages, a different development of services. Why is it the case that we haven't seen the development of services in France? The red areas are sort of areas with not so much development. Why is it the French have done things in a different way? Why is it that the Switzerland has an extensive network? Why is it the Dutch have done well? The Spain, we'll hear from Professor Arango, services there have been very much linked to research. Research funding has been a key driver of the development of services. So just really to finalise, there was a slide on economic evidence, but really that's really just saying there is an evidence base out there, and it perhaps is significant that I believe that in countries where there's been a demonstrated economic case for investment, they tend to have better developed services. I'm not saying the two are equally linked, but it is the case that if you point to Denmark, you can point to economic analysis. The UK, Australia, Canada, Hong Kong, you can point to economic studies that justify the investment in services. So to finish really with these very brief points, some of the factors, the barriers, and particularly the facilitators here that can help service development in different contexts and that will work in different ways. It's partly about piloting. Piloting, it sounds an obvious thing to do, but it can make a difference in contexts where there may be a skepticism as to how different models can work. It may be about partnering with other existing services, particularly primary care, or taking a different approach, as has been done with the Piano study in Italy, and embedding specialist skills within existing community mental health teams. It may be about, again, strengthening the evidence on cost effectiveness and thinking about fidelity. And I was talking earlier about fidelity and emphasising that it's not just about demonstrating the key components of an EI team, but also how can you facilitate implementation, fidelity in the implementation process. It's absolutely clearly about champions. There are places where EI would not be in the state it is without champions like Pat McGorry, for instance, and Marriott Nordentoft in Denmark, who've really driven things forward. But it's also about trying to think about how we can widen access as well. One thing that we noticed in our review is, for instance, the very strong focus, obviously, on younger people between 15 and 35, 15 and 40, but there are a significant minority of people who develop psychosis later, but they tend to get sometimes not as well served by systems. And there's a key final point, my final point, and I hope this will come up in talks, for instance, with Professor Smith later on, about the importance of thinking beyond narrow clinical functioning, thinking about physical health outcomes, thinking about educational outcomes for young people, thinking about vocational outcomes. And I, as an economist, would argue that you can put an economic value on those as well, and that can help, hopefully, in some contexts, and it has, drive implementation through reaching more than simply the narrow health commissioners, but reaching other wider commissioners in the economy. Thank you.
Good evening, everyone. My name is Fel Sorango, and thank you, Professor Jones, for putting this together. It's great to be here. For those of you who do not know what I am doing here, I think it's quite obvious. You have heard all the action that is taking place in the UK. You will hear all the action that is taking place in Denmark. And they needed someone on the other extreme, right? A country which is doing poorly, and that they chose Spain. So thank you very much. This is the first time that they invite me to give a talk for doing things in the wrong way. But anyway, I'm here probably for that reason. So what's going on in Spain? Is my conflict of interest. So it's easy. Early intervention in Spain, and this is us, Spaniards, looking at Mars and the Moon from our football stadiums, right? Well, the truth is that there is a little bit more action than this, and actually we are just preparing, and we have a manuscript in preparation about to be submitted, in which we make the case that in Spain, healthcare does not follow evidence, and that's the case of lack of early intervention programs in psychosis in Spain. As Dave McDade has mentioned, yes, there are early intervention programs in Spain, but they are not funded by our national public health service, and it's mostly funded by research money that good clinicians and good researchers manage to get through competing grants. One good example is this program in Cantabria, and we have Benedicto Crespo Facoro, who is leading this program. Before he was Vázquez Barquero, and which provides good service probably to 50% of the population, because again the money comes from funding, so you need to most of the studies they run are randomized control trials, so they allocate 50% to the intervention and 50% to not the intervention. But again, it's probably the best that we can show. The National Health Service gives all the money to the autonomous communities, so the states in Spain, so they can decide where do they want to invest the money that they have for health. Catalonia is probably one of the most advanced states in Spain, and they have started to work on programs for early detection of psychosis. This is a program, this is in Catalan, it says this is a program for young people in mental health crisis. And this is, for people aged 14 to 35, and this is hanging on GPs, offices, primary care, trying to detect those who may be at high risk to develop psychosis. So this is very incipient, very modest, and just starting. Something that is also interesting, and is that, and I will talk about this later, is that some of the very few good examples and good units that are related to early intervention are like this one, private foundation run by family associations. So it's the family associations themselves who manage to get money and provide this service. I think that one of the reasons for this, and then to get some money, some public money, is because, as I will mention, most of the decisions in Spain are not evidence-based, are based on political issues. We're a very political country. This is an effort that all large hospitals in Madrid have done in terms of assessing all first episodes with the same criteria, with the same tools, with the same scales, and do a follow-up of those first episode psychosis. Again, this is money that comes from competing research grants. But it's it's a step forwards and probably a way to convince our politicians to invest in these programs. This is the program we have in our hospital. It's called Piensa, which in Spanish stands for Think, and it's for children and adolescents with either high risk to develop psychosis or a first psychotic episode. We do work with families and with family associations, and that again is probably the way to move forward, at least in Spain. And the last two slides, and this is thoughts that we are integrating in this manuscript in preparation. Why do we believe that we have such limitations as compared to other neighbor and European countries? Well, a public health system focusing chronic diseases and long-term mental disorders traditionally in Spain is quite difficult to convince the people that have the money to change their minds. There are almost non-existent coordination between mental health specialists and primary care, welfare services, or education. So, if you try to recruit ultra-high risk subjects, it's quite difficult, and the educational system and primary care are not well trained to detect these cases. Inappropriate organization of resources, long waiting lists, and long periods of time between visits. We spend the total of our health budget, we spend 5% in mental health. That is 2% below what is the European minimum, around 7%. So I think that's because our politicians have this probably false perception that mental health does not kill. So this is something I cannot sell for the next election in 4 years' time. Well, this was when we had elections every 4 years in Spain. Now we have them every 3 or 4 months. Actually, we may have the third elections this year in December if they don't come to an agreement. But anyway, so it's probably getting worse. Rare access to psychosocial services. Impossible to offer integrated treatment. So it's very divided, very fragmented in services, and no guarantee of continuous of care. One of the major problems we also are facing nowadays is how we lose adolescents when they reach adulthood, and there is no continuity between the child and adolescent services and adulthood services. Physical spaces not adapted for young people as the ones we have seen this morning, and that we probably will see later on. And lack of commitment, again, on political interest in preventative measures. So they truly believe that this is not going to give them votes for the future. And that's why I do think that we have to go hand with family associations. Thank you very much.
Well, thank you for staying on. I'm going to present you a good example, I hope, about how early intervention services were transferred from research to standard care. I'll do this, yes. These are my disclosures. We got some funding for the trial. It all started with the Opus trial many years ago. We started in 1998 with recruiting the first patients, and then we have followed them up for 10 years after the first recruitment, and we are going to apply for funding for a 20-year follow-up. But what we can see is, as you can see here in this figure, and I know it's a little bit difficult to see, but the full lines are opus treatment and the dotted lines are standard treatment. And what we can see is that with regard to functioning, which is the split version of the graph upwards here, we can see that the opus people are better functioning than standard treatment. And it goes on for the 2 years where the treatment is still active, but after 5 years we cannot see any difference any longer, and not after 10 years either. And when we look at the symptoms, they're going downwards. It's the negative symptoms with blue and the psychotic symptoms with red. And the full line again is opus and the dotted lines are standard treatment. So what we can see is there's a clear effect on both on functioning, but also on psychotic and negative symptoms while the treatment is still ongoing, but also that these clinical effects disappear after 5 years. And of course, I think it's very encouraging to see that it's possible to influence also the negative symptoms because they are very you get a lot of disability from them. But of course, we were disappointed to see that we couldn't have long-lasting clinical effects. But on the other hand, do you have any examples of drugs that last for 10 years after you have stopped taking them or things like that? I think you can argue that, of course, there need to be some kind of booster sessions or something to maintain this difference in outcomes. That was the first piece of research we did, and then we did a meta-analysis, which is pictured down here, the results of the meta-analysis, and it is about the proportion of people in early intervention services admitted compared to people in standard treatment admitted to hospital. And what we can see is that it's possible for early intervention services to reduce the risk of readmissions after a first episode psychosis. And then, as James said, there's also been a health economic analysis. I was so obedient, so I didn't take too many slides, but I have slides demonstrating that opus treatment is cheaper and better, and I think that that really convinced the politicians. Of course, they were interested in the clinical effects and also in the effect we had on service use, but when it was calculated that it actually, in the end, was cheaper, I think it was rather easy. So this is a map of Denmark before opus was invented, and this is what happened. Hopefully it works. Yeah. So now we think that all over Denmark is covered. It's not covered with the same intensity, and there might be places in Denmark where it's still not possible to get into opus treatment. But we are working on it. And recently we've had a discussion with the regional health authorities because they wanted to make opus, I don't know if you could call it a civil right, but it's a treatment package, and we have treatment packages for different things in Denmark. We have for anxiety and depression, and if you have such a disorder, you are entitled to be offered a treatment package within, I am not quite sure about the number of you are entitled to be to have an evaluation within 1 month, and then briefly after that you are entitled to go into treatment. So there was a lot of discussion about how should such a treatment package be composed, and we had a group, a task force that worked on a draft, and it was discussed with the politicians. It came back, and we were very angry, and they said it can't be better and things like that. And after a while, we ended up with this agreement. And I think we both, the health authorities and the psychiatrists and the mental health workers, they think that it's a good solution. Because what it describes is which elements should be part of such a treatment package, and how often should you be seen, and which staff groups should be involved, and what kind of groups should be offered, and what kind of treatment. So I think there's a lot of things that can safeguard the treatment. We also have the opus fidelity scale, which was mentioned earlier today, but this is sort of a planning tool. So we hope that we can get a lot from that, and not at least in in the areas that are not that well covered with the treatment. They can say that this is actually what we are entitled to get. So I think it is a huge step, actually. So if I should conclude something, I think it is very important to get evidence, and we have evidence, and then guidelines. There are both national and international guidelines, and then to influence the politicians. I think you can't underestimate that work. You'll have to go to the politicians again and again, and you'll have to also work together with user organizations and keep up the work with the lobbying and things like that, to move forward with the political decisions. And then hopefully the government will give you starting grants several times. And then I think there's an important issue about maintaining everything. It is to have good educational material, handbooks, manuals, videos, training courses, in order to make it available for all the people who are to do something, that they can actually know what to do. A fidelity scale, accreditation, something that where you really assess whether this is what you intended it to be. And then national and international conferences like this one to share ideas and keep up the good spirit. So I think that would be my recommendations, and I've pictured this in this circle where you can have an RCT demonstrating the evidence, in most cases several RCTs, sum it up into guidelines, monitor or make some accreditation, and then have good leaders who actually are able to implement something, and to have education in order to make things, to have the real content in what the service should be. And then I've had something up here. I think creative thoughts, not to make things too rigid, to have room for new ideas. I think virtual reality is one example, but there could be many others. To have space for creative thoughts, I think that's very important. New ideas. Yeah, that's it.
Be a test of my eyesight, actually, from there. Now I'm getting older. I'm going to talk about best care practice model from England, and so the title actually is a slight over-exaggeration of what I'm going to cover, because most of the developments in early intervention have been in England. That isn't to say that in Scotland there remains 2 early intervention services, as there has been for a long while. In Wales, there has been some rollout and some developments generally around psychosocial interventions with some funding. But really, if you look at it, you see possibly 1, 2 health boards where you would say there appears to be what one might describe as fragile early intervention services. So I'm going to talk about England. That's the first thing. Those are my disclosures. Okay. I don't know whether in different countries you have something called Bake Off. Do you have Bake Off? In England, it's on at the minute, and it just captures everyone's attention because it's where you get all these people and they're given a set of ingredients and they have to create something, and then they get judged on it. And it was interesting, I was reflecting when doing this talk, going back to the late 1990s, and if Max is here, he'll probably remember this, as with David. We were working in something called IRIS, and we were working alongside the Birmingham Early Intervention Service, which was our first model which we used, because we paired both the aspirations in terms of what EI services should look like with a real EI service so people could see. And we won an award. We won a national award called a Beacon Award. And we were quite pleased with ourselves in terms of that. And then someone actually said, a beacon is actually a warning. It keeps ships off rocks. And I think that's one thing to remember about beacons, because sometimes you can become complacent as a beacon and you don't actually change, and you spend your whole time telling people about what you've done, that you cease to innovate. So that's my first message. So here we are back in Bake Off, and I was thinking about this, and it describes, the first thing is about the national rollout of EIP teams. And it talks about that in terms of the mental health service framework that came out in 1999. But I have to say, prior to that, prior to any policy, there were years of lobbying from both out of the orthodoxy groups, non-government organisations and individuals who are dissatisfied with the current service. And I think your biggest ally are users and carers as voters and taxpayers expressing dissatisfaction with the status quo. That eventually reached the ears of government, and we started with this mix, which was a national rollout of early intervention in psychosis teams, supported by policy. IRIS, which was actually a virtual group made up of 5 of us who met in a room from different NHS trusts. And I remember describing it as emperor's clothes and saying, well, where's this going to lead us? 5 of us trying to influence national policy. But we actually laid out a vision, but it wasn't an aspirational vision. It was based on the evidence that existed. And it was based on what we felt influenced by users and key carers, people like David, talking about the aspiration of the kind of services they would like to receive. And I still look back at those IRIS guidelines, even with their revisions, and there is nothing I would change. But I would add in innovations and perhaps different emphasis. And the emphasis I would add would be on education and vocational functioning, social recovery, and addressing physical health. Those are the 3 things that were not articulated so strongly in that. So we had a specification which was embraced almost in its entirety into a policy implementation guide. We were concerned when we first started around about 2005, we did an audit, and what was quite clear was that people were describing the development of services as a service, but when you looked at it, and I've been quoted on this, it was a man, a dog and a chair, and they called it early intervention, and there was no way it could achieve what was laid out in terms of what an EIP service, what we were articulating. And that led us to specify with government some minimum fidelity criteria. We identified 10 criteria. And in fact, in the appraisal that Vanessa Pinfold, myself and David were involved in that audit, that actually across the country by 2007, we had a mean fidelity rating of over 6.5. But you can see the range is from a man and a dog in a chair to a totally faithful model. What we also had was we had a minimum data set reporting. And that relied on 2 things. It asked people to report on whether they had a team or service, and there was some confusion which still remains over teams or services. We had new early intervention cases, and we had total caseload. And every trust in the country was asked to report on that. And I think having a national reporting system for all its failings and bureaucracy does hold some accountability, particularly when you rely on local commissioning. We had a leadership programme. Initially, we were out of the orthodoxy. And the irony is, people like me, when we got this policy, said we need a project management team, we need leadership. And I wrote a job description for a national project lead, never imagining that I would then apply for it in a job share with David Shires and become a national lead for 7 years. But actually, that leadership programme actually led to the appointment of regional leads. There are many of them in the audience, like Paul French, Guy Dodson, Stephen Moggy McGowan. And we formed a network. We linked together EI services within regions, and they had regional leads, and those regional leads were linked nationally. Now, I feel that was critical in the bake. It allowed us to feed the beast, to feed government with data, to answer questions in Parliament, because we could go straight through that network. We had relationships, and we could get information. But equally, we could feed information in. And we were into being good guys in class. If anything was needed, we were there. EIP will help, we'll help. And we also, and I think most importantly behind this, is evidence is important. That's head, and you do need head, but you also need heart. Because actually, the people that you're appealing to in government do not necessarily respond to evidence. They respond to heart and they respond to narrative. And you need a twin chariot, head and heart, to ride together. And I think one thing that actually stands out in the early psychosis movement in England was the value base that we drove very hard through it in terms of combining narrative of users and carers and telling stories to politicians about what it was like to be a young person with first episode, what it was like to be a family member. But we also supported that with head for those who, like Thomas, needed to put their hand in the wound and needed to see the evidence. And yeah, it was fragile when we started, but we grew that evidence. And if you see the accumulation of papers and research, it was incredible. We became the fastest producing evidence base. And I have to say, that was to the credit of researchers in the UK, like Max Birchwood, like Tim Kendall, lots of different people who actually very generously donated data prior to publication to allow us to use it to inform political arguments. Because if we'd waited for publication, we'd have missed our timing. So it requires a generosity which goes along with that value base. So there was a rise in EIP teams. Some of you have seen this. There was an investment, 104 million over 10 years of the National Service Framework went into early intervention. And with it, we saw a massive growth in early intervention capacity. We expected to see 7,500 new cases of psychosis a year. So over a 3-year intervention period, we were expecting 22,500 to be served by EIP. And at the end of the NSF, we had just over 21,000 cases served. We had almost 95% coverage with EIP. And that was supported by colleagues who I can't rate highly enough from London School of Economics, people like David, people like Martin Knapp, who supported us in terms of economic modelling and taking data. And I always remember going to see Martin Knapp with Paddy Power, now in Ireland, where Martin said, well, I need data, I need it. And Paddy, who'd come along with, pulled out of his suitcase and said, well, would this data from Leo help? And Martin looking at it and saying, yes, that's exactly what we need. And that led to the first cost economic, which showed the value of EI. So we had a mix. And that was also supported then, amazingly, and I have to say this, I don't know whether Tim is in the audience, but Tim initially was a sceptic. And there were many skeptics about EI, and people like Max, myself, various people had to stand on platforms being lobbied, challenged in terms of where was the evidence. But in 2014, we had the evidence there. So we had head there, and we survived the appraisal of NICE, and it came out saying that, in fact, anyone with a first episode should receive timely access to an early intervention service. But that was further supported by our cost economic colleagues who added in further data showing not only that EI as a package was helpful, but also other elements added value, like the investment in educational and vocational recovery, like the impact on outcomes in terms of suicide long term. It all looks great. Now, I remember standing in 2015, I was a keynote at the International Mental Health Leadership Conference, and I actually went on a platform before Norman Lamb. How lucky is that? Because I stood up, I was asked not to talk about EI, but I was furious at that point, and I was furious because no matter what you say about evidence and about value, I went through taking an angle from economy, not from mental health, looking at how we appraise value in companies in terms of assets. I looked in terms of leadership. I looked in terms of knowledge capital. I looked in terms of evidence, in terms of effectiveness. I looked in terms of value, in terms of cost savings. I looked in terms of spiritual capital, the values that EI espoused. I took every angle of value which in any other system would actually shove you up into a FTSE 100 company because you ticked every box. And I said, and I'm trying to understand how mental health services, how commissioners, how government, how you are appraising value. Because it was in the context of this, where despite all the evidence of value, what we had was that we saw a decommissioning of very effective, cost-effective EIP teams, where there were significant cuts to over 50% of EIP services. And from that 95% coverage, in a recent report, we saw that then only 2/3 of the country were actually having EIP teams. And I would really question whether actually cost economic data, effectiveness data is enough. Because I don't think in mental health we actually appraise value on the same basis that any other business would actually base value. Now, I was lucky because Norman Lamb heard me speak at this huge conference. And he said afterwards, we need to talk. And I'll come back to that. So, we have actually seen a reascendance, and I'll come back to Norman Lamb in that, because I think he was critical. And the reascendance was, as Peter described, the access and wait time policy. And Peter's described it, that 50% of patients experience a first episode psychosis will receive a NICE approved early intervention psychosis care package within 2 weeks of referral. And on top of that, that there would be a 3-way stretch, that our age range in the UK, which was 14 to 35, would go up to 65. We managed to stop the all age when I said, actually, there is no evidence beyond 65. You're on flimsy ground over 35, but actually, I'm afraid there's no evidence for EI. And there's risks with that we take away youth focus. The stretch was also to open up EIP teams to at-risk mental state, and which probably means about a 20 to 25% caseload increase that requires resource, and NICE quality standards concordance. With that came funding, 33 million to build capacity, largely went into training staff, £40 million recurrently, and a lot of developments put out earlier this year in terms of training around CBT, family intervention, IPS, but also with it national benchmarking. And as you can see, what that showed, that at the minute there are 144 teams, 80% are standalone specialist teams, 63% sticking to that age group, but obviously now being required to go higher, but 24% going up to 65. Majority 3 years intervention, but much smaller numbers offering CBT or family intervention. And interesting with Cymaptic, a Northwest deep dive showed that for all of the EIP teams in the Northwest, it was 198% under prediction using Cymaptic. So, my conclusions. Number one, you need challenge and lobbying. It's no good just relying on evidence. You need challenge and lobbying from out of the orthodoxy, and I think that's where we started with IRIS and Rethink. But also you need political lobbying. And people like Norman Lamb I will hold up as an MP who has lobbied behind the scenes and I think has been a great ally. You need allies in government to support you. You also need independent authorities, and I think that's where people like NICE have come in terms of actually validating what zealots like me were saying. I think you need the narratives of young people and families. That's the heart bit. You also need a heart in terms of values, but you need to pair that with head in terms of the evidence base and the cost economic evidence base. You need a national government priority that this is a must do. You also need fidelity criteria, data set report, because all of those things tie in accountability at a local level. If you don't have that, there's no accountability, only local accountability. But I think more importantly, you do need leadership. And you need a sustained leadership, and you need to create a network and a knowledge community and bring people together. And that requires collaboration beyond your research project, beyond your service, altruistic giving to support the greater good for a growth across a country or internationally. You need to keep EIP as a priority. It's got to be a success story, a solution to other problems for government to listen to it. And finally, you need to avoid complacency. You need to adapt and evolve the EIP model to meet new policy demands, changes in structures, new issues, new evidence. Thank you.
If the panel would like to join us. We're now moving into the last part of the session where really we want to interact with everyone in the room and hear your thoughts. And I'm going to hand over to Dr. Antonio Laura from the Lecco General Hospital to chair this session. Antonio.
The goal of this panel is to start a discussion with the person that presented before on the perspective and recommendation concerning the implementation at system level of services for early intervention. And we start the discussion between the audience and the panelists. We start with the experience of the panelists expressed before. Before starting, I will introduce Dr. Swapna Verma, that is the Chief of the Early Psychosis Intervention Services in Singapore. So, we start with the question from the public.
Any thoughts?
Shyness.
Mr. Beck, there's a...
So, hello, thank you for wonderful presentations. And my question is, when you're trying to convince governments to strengthen, in this case, early intervention, or open new clinics, put more money into it. What types of evidence are the most influential? What do governments really look at to make the decision to spend more money?
I think you have to show value. And you have to show impact. I do think you need both of those things. I certainly do feel the one thing is that you're working, health timeframes don't fit with political timeframes, and you have a window, and you have to deliver within that window. We were in the Blair government, the Blair Labour government in the NSF were particularly focused on how things appeared. There was a lot of spin and a lot of... And so if the Blair government set a target, if it didn't achieve so that they could spin about it, that target disappeared. And they only want to back winners, and they've got a time frame within which to back winners. And you've got moving targets because, of course, you have changing governments and change. I think Pat was saying, I think they're on their 4th or 5th health minister. So you have to keep on that process, but you have to give them winners that give them profile or that they seem to be helpful, but they also want evidence that you're going to save money or somehow influence a problem. I think the best advice I give you is not to go to government with a problem. The government has enough problems to solve. You need to go and take early intervention as a solution to one or many of their problems. So, for example, in the UK, parity of esteem. They want to demonstrate parity of esteem, and so you talk about how, if we invest in EIP and we focus, we will actually deliver in terms of physical health outcomes for you. If you go as a problem saying we want you to sort of go, they've got millions of mouths to feed. they've got millions a month and you're just another problem. But if you go as a solution to a problem that you know they've got, like problems with youth or problems, so you look for the kind of political, I spend my whole time scanning political policy and political messages and thinking, how can we respond and talk to that with EIP as a solution? That's my advice.
Hi.
Yeah, I have some advices too. I think there are several answers. I think the evidence is important, but I might agree with you, Joe, that evidence cannot stand alone, and maybe something is even more important than evidence. And I think in Denmark we've been very privileged because some of the patients in our services, some of the users, they have formed a panel of people who would like to tell how it is to live with an invisible disorder. And they are willing to be interviewed in the media. They are willing to go with us to the parliament and argue that this should actually be implemented. And I think to have a strong voice from the users and in some cases also the parents can be very important also. So to work with the media, and I think sometimes when I must explain how do we implement the search function, then there's one thing, it is never say no when you are asked to do something. And of course you can't say yes to everything, but if you are asked to give a presentation in a user organization, if you are asked to do an interview, if you are asked to go to the regional health authorities to explain, say yes.
I think the experience from Singapore also has been pretty similar. The difference was that in Singapore, when we started the early intervention program, it was really the service was very tertiary care based. The patients were coming to see a specialist. So we really were instrumental in developing the community capacity and competency. And then when we wanted to have more funding, become a national program, the community counsellors and workers, they became our biggest advocates because they saw the value in having an early intervention service, and they felt that they couldn't do without it. And another thing is that within 4 years we were able to reduce the DUP by more than half. So that was the biggest impact. So having the evidence as well as the voices of the patients and the community, that's what we want.
A question from Dundee Shoes.
Hi, thanks. A fantastic sort of range of experiences, which is amazing. I wanted to just ask a little bit about professionals. So I remember in the late 90s coming into a service with my daughter where all I encountered was therapeutic pessimism. There was a sense that nothing could be done. When we tried to complain about the system, we were really ignored because this was as good as it got. And so that aspect of coming across professionals who had very, very low expectations, which then reflected on us as family members to make us have very low expectations. And I think what we haven't discussed today so far is how you carry a culture change within professionals. So we've talked about research and we've talked about government policy. But for me, there's another ingredient here. And professionals aren't just one sort of professional. They're obviously there's the world of mental health professionals, and in that it's an interesting blend and mix. But then you've got the places of people like me as GPs, and how my pessimism as a GP in the late 90s made me very reluctant to engage services for people that I work with. So I just wanted to ask a little bit more about how you see the role of professionals.
It's crucial because if we professionals do not believe and we are not more ambitious in that things can be changed, then we're not going to be able to transmit that to politicians. And sadly enough, when we when we ask for more investment in our area, and most of the times we're competing with other medical disciplines. And there's a limited limited resources, limited budget. Most of the times the money goes here or there based on what politicians think can be changed. So if we do not believe that, and we're not able to talk about concepts like therapeutic window and opportunities that we cannot miss, and who will say no to increasing the quality of healthcare and by saving money? No, right? But I guess if we don't believe in that, then we are not able to convince the ones who have the money.
I've just seen Dr. Swapna as well.
I think, David, you really brought in a very important point, because even in Singapore, I think we've changed from really focusing on symptomatology and medications to really a strengths-based recovery model. And I think the culture of the team has changed drastically. We really kind of focus on the strengths, identify goals for the patients, and then work hard towards that. I think one of the key things to get that change has also been getting peer specialists on board. And I think that has changed the whole team culture. Our language has changed. When I see patients, I see myself treating patients very, very differently. And so does the team. I think that has made a huge difference.
I was going to say something in relation to, we divide people up into zealots, middle ground, and laggards. And whatever your arguments, it needs to appeal to middle ground. But you also need what I call horses for courses. You have to package up your arguments to suit the audience you're talking to. And so different audiences have different needs. So if you're talking to inpatient staff, you have to look at how early intervention might impact on hospital admission. In terms of, for GPs, it might be about access, speedy access for poorly young people. If you're talking to users and families, they're looking for a family-centred service. If you're looking for colleagues, part of it may be about you altering their workload. And certainly I think we won in some areas in terms of certainly rehabilitation services who are seeing less people coming through than previously. And we had in our service, a rehab and EI psychiatrist who said, definitely, you've made a difference, definitely. There are less coming through and less impairments. I don't think in the UK we won over some of our other team colleagues. I think we work very closely with crisis and home treatment very well, and I think they're effective relationships. But I think particularly community mental health teams were left beached with all the attention focused on early intervention. And I remember a slide we used to show of EI as Titanic going down and the sharks in the water, saying we're absolutely pleased that that ship has just gone down. And I'm sure colleagues would in this resource-strapped system that we need to think about a whole system. One of the things I don't think we've paid enough attention to is implementation science, which is now really, really developing. And if you look at things like normalization processing theory or many of the other implementation science models, some we've done by accident, but I think we could use some of those frameworks, and culture is one of the most important things, because you can have leaders, but you've also got to create a culture in which something can grow, survive, and be sustained. And I think we need to look to models outside of mental health in terms of implementation science to begin to look at some of those issues that I don't think we've fully grappled with.
Question from Mr. Solano.
I had a question because it's pretty clear that here at this table and probably the audience there are people from countries that are different speeds, and for those of us who are lagging behind 10, 15 years, it's amazing to see what you have done and what you have achieved in this past decade. There's, I guess, one advantage of starting right now is that we can look at all the good decisions that you have made in the last 10 years. But probably you have also made some bad decisions. And if you will start now, what you started 10 years ago, for those of us starting now, what recommendations would you make to us in terms of not going that direction, or what things would you be doing differently?
Okay, I'll start. Again, I think then I'm talking from Singapore perspective, where when we started, we really did not have a primary care or secondary care model. It was mental health was based in a mental health institute, very tertiary. So we started the intervention, we launched our early intervention service from there. But I think looking back, I think we should have started in the community. So identified ourselves really as a community program instead of still being based in a hospital setting.
Yeah, I think I have some advices as well. If I look back on the last 20 years, I don't know if I could call it coincidence, because of course it's not. It's also willpower, but it's not organization. And I think if we could have organized ourselves better at an early stage, we might have been less fragile. I think now it went well, but it was mainly due to a lot of people doing something against some odds, at least. They did it because they wanted it, but I think if we could have organized ourselves stronger, I think that would have been an advantage. And then I think to involve the users more closely. I think we did that to some degree, but I think we could have done it better and stronger, and it would also help with the pessimism, I think. And I would also say one thing more about the pessimism is long-term follow-up. I think even when I started in research, I was surprised just to see the 2-year follow-up, that okay, a lot of people did better. So to have long-term follow-up, at least I think scientists can react to that.
People will know in the UK that I'd probably say I wouldn't publicly shame someone who turns out to be a key ally in government, which is what I did. It started off the national programme by asking someone to go back on stage and talk to an early intervention audience. It wasn't a great start, but it became a key ally. So I would certainly keep away probably from criticism, but be open to the fact that people may change opinion if you can actually convince them of their value. I agree with Maretta. I think the initiatives that we've seen internationally and certainly in the UK in terms of peer involvement in services and really holding user and carer voice and narratives, that actually is critical. And I think because general public, and most ministers and government are just general public, they want to hear stories and stories which they can relate to. It could be their sons or daughters or their spouses. And I think using and harnessing, not using in a negative, but actually harnessing that and seeing the strengths of that alongside evidence is important. The other thing I think I certainly would do differently is we're here looking down and drilling down an EI. I think if I was doing it differently, I'd try and look at a whole system and pathways, because I think the one thing that no country, including some of those where it's well developed, have really sorted the pathways beyond EI and the longer term outcomes, and still the data is showing there are losses. And so if I was starting now, I would try and take a whole systems approach and think how we can keep that going beyond the 3 years, because I don't think we've cracked that.
That's a good point. Yeah. Antonio, I can see the room. There's a lady there, and then Pat McGorry, and then the gentleman in the check shirt.
Rita Roncone, L'Aquila, University of L'Aquila, Italy. I appreciate so much the presentation, our speakers, very compliments to all. Well, I come from a little town in Italy, 100 kilometers from Rome, and 10 years ago, with some colleague in L'Aquila, we opened a service for early intervention. It was at the beginning called for early psychosis, but now we just say early intervention. We don't have any kind of support, and despite any kind of, we never pose any kind of problem. We just arrive just proposing solution. But I think that I appreciate so much, this kind of attempt to solve the problem, community service, but we need organization and we need the human resources. So in a country like Italy, a university service working on this kind of subject doesn't have any kind of resources. So that's reality. Any kind of support from our local and regional governments. So I'm not waiting for a miracle because I think that it can't happen. But I would suggest, we got also a representative from Italian National Health System, Health Minister, sorry. And I think there must be sort of compulsory suggestion, compulsory suggestion is a contradiction, but a compulsory, diplomatic way to say that it's no more any kind of trying to convince people about the value of what we do. It must be compulsory. It must be sort of thing, that you have to do, since there are so many data now, since we are working since 10 years on this kind of subject. So I ask a sort of concrete help from our government. Thank you.
You mean I have to answer immediately? I am giving some closing remarks, but no, this is the Italian case. I will. Sorry, I am intruding because I am supposed to give some concluding remarks on a general approach to the problem. But since you are asking directly the Italian case, I should say that it's not true that there is no support. First of all, we have to say that we are a sort of federal country, so we only can give at national level framework suggestions for strategies, and the responsibility for the organization of services is all up to the regional authorities, which means that we can do something else to push it. One thing we are trying to do is to allow for a continuous monitoring of what is really happening in the different regions. I don't want to change completely the subject, but I want to give you an example. I work in the world of the area of mental health with a focus during the last years on the dementia issue, which is on the other hand completely. But we have learned from the mistakes we made in the past concerning the mental health strategies that we approved. And this time in the national plan for dementia, we put as compulsory the monitoring of the implementation of the national plan into the regions. And for the last 2 years, I am coordinating the table where all the 20 Italian regions are sitting, and we are seeing and pushing the local authorities to go on with the implementation of all the recommendations that we have agreed upon, because also the national laws in the health and social sector have to be agreed upon and signed both by central government. So I think we will multiply our efforts to try to do the same for this specific issue, which is included in the last national plan. Of course, it's less implemented than it should be, but we will see afterwards. Sorry.
Yeah, thank you. I think it was great wisdom from the panel, but I just want to say, I think what Joe said mirrors our experience in Australia very, very closely. All the things that you said, it's like a blueprint for how to do things. So I think we should all get a copy of your slide there. Just make a couple of quick comments. I think in mental health generally, it's appalling the situation around the world, really, in terms of the investment in mental health care. I don't know if anyone's read Fuller Torrey's book, American Psychosis, to describe what actually happened in that country. But it's really the same everywhere. And I think Celso's slide showing the chronic underinvestment, especially in community care, is still a worldwide phenomenon. And this has been a bit of an aberration in some ways, and for the reasons that were described. And I think our experience in Australia would be to go much more with what Joe was saying about the heart, because the evidence is for us in a way. It's to make sure we don't do it wrong, we don't do the wrong things for patients. That is not what convinces anybody else. It's an insurance policy, actually, and we've got to do it, of course, and we're all the reason this has worked is because we are clinician researchers. But we've just seen in Australia how we had a major reform which had incredible political support for 10 to 15 years, and despite all the evidence, they were quite willing to let it go and to cash it out and let people just commission what they felt like commissioning, irrespective of the evidence that had been built up over 25 years. So there's no respect amongst health bureaucracies for evidence, actually. So I think what we have to do is what they do in cancer. Now, cancer, a lot of people still die from cancer, but they invest incredibly heavily in it. And they don't have to do cost-effectiveness studies. You don't see the cancer advocates or specialists doing London School of Economics, not to deride what David said. We've done exactly what you said too, and it sort of has worked in a way. But we shouldn't have to do that. We should not have to do that, because the value proposition of trying to save lives for cancer is what a civilized society would do. And a civilized society would also try to prevent deaths from mental illness and guarantee futures, irrespective of the cost. And the fact that it's cost effective is a bonus, actually. But that should not be the main argument. We're going to lose if we go down that track, actually. The heart is the only way to go, and we must back it up, as you said, with the evidence. And you've also got to we've got to get out of this silo, which this organisation is doing. If we just try to defend the citadel of early psychosis here, we won't get anywhere. Because the big numbers are in mental ill health in general in these age groups, and that is what has got us political support in Australia. We got nowhere when we advocated for early psychosis. It took us 20 years to even catch up with the British. And the reason we had the huge surge was because of the broad focus on youth mental health, because every family is affected by that. If you have more than 2 children, one of them is going to have a problem. So that is the winner, and that's what my advice would be.
I'll come back to that, which is about looking for arguments where early intervention becomes a solution to someone's problem. And it has to be to problems in the voting public, and we saw it actually in the slides that were shown about the ageing population. Most countries with the age demography are concerned about pensions. And the only way that actually those pensions are going to be secure is if we secure the workforce of the future. And young people are the workforce of the future. We have evidence that if we protect the mental health of young people, they will be productive in the workforce. Now that's an argument in this economic climate we're in internationally, that actually where it appeals to people who are so far removed from mental health but are concerned about their future, to say the investment in the mental health of the population, particularly young people, in terms of is an argument, and we have to look for things like that. The other comment I was going to make, which Pat well remembers, Pat invited David and myself and a couple of colleagues from government to go out and review your services, and part of it was quite shameless. We actually highlighted to government a profit in their own town isn't heard, but someone else coming from outside shamelessly saying, gosh, this is brilliant, gosh, if we had this in England, if we could roll it out, that actually at that time led to an investment from government. The other thing is about co-leverage and leapfrogging, because actually we have used the experience in Australia to develop what we had in England, and other countries have come to England and developed elsewhere. And I think there's something underpinning again in terms of value base, which is about altruism and sharing. And I think there's a value base that needs to go in this culture, in a research culture and a service culture, of altruism and sharing to support other countries, other services, share research, grow good practice, and that requires another value base, which sometimes can be counterfeiting to a research culture. A research culture which protects, holds, we don't want to share what we're doing in case someone takes our ideas. We have to overcome that with a different value base that runs through it if we are to survive, and a culture of sharing and altruism.
Yeah, thank you. I also have some comments. One thing is that mental health disorders or mental disorders are as common as cardiovascular diseases and cancer. We had a publication in Denmark where we looked at how big a proportion of the total population will get into contact with secondary health services, and it was 1/3. And that's secondary. So I think what Pat's saying, if you have 2 children, one of them will become ill, or 3 children. I think that's definitely true. So I think that we should compare ourselves with the Cancer Society and the heart organizations, and also learn from what they are doing, how they manage to promote themselves. I have a person in my family who is involved in child cancer, and they're so rich. they get such a lot of money. Of course, it's also heartbreaking when a child gets cancer, but they cannot be allowed to pay for themselves for anything because they just get money all the time without. And I think we should put ourselves in that position to be something that's valued. Then I think it's a false dichotomy to think that it's not evidence or promotion and speaking about values. I think the evidence, it serves to unite ourselves, to strengthen our, what do you call it, robustness inside, or authority, and to make sure that you're not suddenly somebody from the National Board of Health say this is rubbish. So I think we need to have that as well. But I think to have it together with promotion, and a colleague of mine suggested today that we should have a national collection of money. Not necessarily because we needed them, but also to make this TV event where companies said, we donate this and we donate that, in order to destigmatize and make this is everybody's business.
Another question?
Hi, Alan Rosen from Sydney. If we're going to say service users and consumers and families are key resources to this network, why don't we role model it in a conference like this? We've been going on for years and trying to get a structured session in that is an open session to at least local families and consumers. The cost structure of this conference has traditionally been too focused on service providers and defocused on having consumers and families' voices appear at sessions like this, for instance, in considerable, significant numbers. So can we change, rather than just relying on the Youth Mental Health Conference, which does have the critical mass, but can't we get the critical mass here, or at least a significant mass? The other thing is, and this is an issue of the heart, that's an issue of the heart, but also the issue about therapeutic optimism and instilling hope. They're issues of the heart, yet we can find evidence for them. And we can find the evidence base, but we can also operationalise and we can manualise that stuff, and we can make sure that our service providers are trained in it, so we don't have to live with services that are sinking in therapeutic pessimism. So why don't we operationalise that ourselves? Because the issue is, if we teach therapeutic optimism as part of our programs, why aren't we operationalising it by training ourselves in it and making sure that we use it routinely? The other issue is, I wonder about England and whether we're going to be dealing with these issues and going on with them. So we're very interested in what everyone said, and I think there's been some fantastic solution focused talk. We're going to have another session on this on Saturday afternoon because of the Australian dilemmas and the English dilemmas. But the question is the situation in England really a Faustian pact? Is money really everything? Is taking that money going to do what I think David and I have played with in the Early Intervention Journal about providing ripples to other age groups, which we should do. And I think we're actually mistaking two things. We should protect the services that actually make a difference, and we have good evidence for them, and we know that that's the big age group where most of the incidence occurs. But why are we then widening it shouldn't we have another strategy, like making sure that the youth still have a youth-friendly space to have the early intervention services, and then have another component of service for the other age groups? Would that actually preserve where the evidence base is strongest, where the heart is actually most acutely affected, if you like? So can we actually do something about that rather than just taking the money and widening the service? Although I think it's a fantastic opportunity, but can we be strategic about it?
Before you respond, Joe, could I just say that we've got a gentleman there with a question, then David McDade, and then David Fowler, and we've got about 10 more minutes to get all that in. So.
There were there's an expert reference group with a lot of very experienced researchers, clinicians, working with government and really trying to preserve that youth focus, because I actually do feel that's, for me, if we get it right for young people, that actually is the essence of EI. However, having been a clinician and a service lead within an EI service for the last maybe 20 years, what I would say is we're not dealing with a single group within an EI service within 14 to 35. You know, a 14-year-old is very different from an 18 to 22-year-old, is very different from a 25-year-old, is very different from a 30-year-old, because actually they're in different phases. Some are in education, some may be married, some may have children. And so actually I do think within the EIP model, we actually serve a series of different population groups, some of which you deliver on an individual basis, some on a group basis. But actually I do think the model has the capacity, particularly around that case management function, which is an intervention in itself, I think, to engage a broad grouping even within that age group.
That's not the question.
Okay.
The question is how we actually make sure there is a youth focus.
Yeah, I think we've already done that within EIP services where we've retained that focus. I think we do. I think we do, because we actually target within the interventions. It's not a single intervention across that age range. That we do actually preserve a youth focus and recognise the different stages and transitions people are in. I think EI has that capacity within the model to do it.
And can we have a separate place for youth friendly?
Yeah, I think again, when you look at EIP services in England, the majority of the interactions take place out of a base. They take place in a school, college, community setting, or in the home. Certainly for most of the audit data, probably 90%, 90-95% are outside of a base. So actually I think the base is pretty irrelevant, except for maybe professional meetings or places where most of it operates outside. So I'm not sure that having a youth base or youth access, and in fact it was one of the arguments for the EIP standards in the current audit, because they talked about having youth-friendly posters and youth access. And most of us within EI were looking at and saying, do you understand, we don't operate an outpatient model, we don't see people in clinics, we see people in ordinary settings, we see them in the home, the school, in the car, we see them in youth centres. So actually I think we do the youth focus, but we don't do it within a single clinic like was perhaps described in terms of Headspace. I actually think it's a very flexible outreach model.
I think we've got I missed one questioner actually, so we've got very little time now because we'll have to finish on time. So,
I'm Ruth Baruch. I'm a clinical psychiatrist from Canada. Excellent presentations and discussions. And I'm just wondering if you can comment in terms of stigma and stigma at all levels, beginning from government, amongst physicians, healthcare providers, and lobbying in terms of mental health. Mental health budgets are very low compared to the other areas, as Professor Magori said, in terms of cancer treatment, HIV. These groups have individuals that lobby. They also have families that lobby very heavily. That doesn't quite happen in psychiatry, among psychiatric patients in terms of patients and families. So I think it behooves all of us who treat the multidisciplinary team who treat these patients to try to decrease some of the stigma and lobby. If you could comment on that.
Yeah, I think in an Asian society, stigma is huge. So it's a constant struggle for us. And I think you need a multi-pronged approach for stigma. We have had national campaigns, and we have done peer specialists coming and speaking out. I think what works also is also a ground-up approach, getting the young people, the well young youth, to be the voice. And I think that is working. So student-led projects, students coming and interning with us and working with the young people who suffer from psychosis. It's a normal experience for them. So it's a very multi-pronged approach, but it's a constant struggle.
Minor point, I mean, heart has been mentioned many times, and I think that hearing a good story can change many things. When that story is heard from someone who is famous and who is, well respected, that probably is more, has a higher impact. And the stigma is probably what makes it so difficult to find that famous or popular people that wants to go out and say, yes, I have a mental disorder.
David, yeah.
Yeah, just a couple of points actually. One in terms of the issue about the funding for cancer, etc. Certainly in the UK, and I think in quite a few other countries, it's the power of the NGOs and the power of donations and funding through donations. And this may be a trite comment, and there may be Republicans from Australia in the room, but actually I think a significant development in the UK is the strong support now from the Duke of Cambridge, his brother Prince Harry, Kate Middleton, in terms of really sponsoring mental health and including conditions like psychosis. But one other point I wanted to make is, and goes back to Joe's point about sort of a whole systems approach. I don't think we've talked about the fact that mental health is poorly funded, and I can think of several European countries, Western European countries, that get less than 5% of the health budget. But then within mental health, the mental health promotion budget is a drop in the ocean. And when we're thinking about dealing with psychosis, depression, anxiety, the whole gamut of mental health conditions, it's also critical, in my view, to invest in better mental health promotion. For instance, to tackle issues like bullying, which can be potentially a trigger for issues like psychosis later on in life. So that's another issue to think about as well. How do we fund that? And how do we address that issue? And that's not just within the health system. If you talk about things in schools, at least in the UK, that's about convincing the schools, the headmasters and mistresses of the schools, to spend their money on mental health promotion. So I think thinking as well at the very beginning about how promotion, mental health promotion, fits into this, I think is another thing going forward to think about.
Another question?
Yeah, it was a reflection really that my experience, we talked a lot about lobbying central government. My experience has been working both at central government lobbying, but as a clinician in my own area, I've never managed to make any changes, even despite being a researcher and a clinician. It's been doing this kind of work at a local level. And there's a lot of work with local councillors, local commissioners, your own local service users. And it's really a reflection that I know that there's skills going on the job, and there's an issue about training and core training and possibly particularly postgraduate training and mentoring people, that actually you learn that this is part of the job. It's not the extra to the job, it is the job if you want to create service change. So it's really a reflection on how do we get this sort of great messages across in training programs, core training of psychiatrists and mental health professionals.
At least I think we all agree. Yeah.
I agree. I think sometimes you can take the view that I'm a clinician or I'm a researcher, but I actually think, one of the things that I learned was that you can use different aspects of your identity. Like, I said to you, when I was talking to Alan, that I was a clinician inputting, I was a service lead. Equally, like David can stand up and talk as a family member, but he was also a GP. And I think we have different roles and different identities, and some of those I think we have to develop, and they do have to be trained. And I think we do have to broaden some of the things that we've been talking about is actually either harnessing the skills of others to support us in some things where we haven't got the skills or training, so working in partnership. You know, and some of the best partnerships we did were things like with Rethink, with the advertising campaign. I shall never forget those postcards. You know, Psychosis, the badge no one wants to wear. You know, if your car breaks down you get an RAC car within 30 minutes. If your brain breaks down, it takes over 12 months. Some of those, I mean, I don't think as a clinician I would come up with that. I think we have to partner with some people who've got the expertise and skills, but appeal to them to work with us. But I do think we need to step out of our band of thinking it's someone else's job to do things. I think, you know, as a community, we could work together and actually harness the skills within here, but we also need to ally with people who have skills that we don't have, hence the partnership with things like economists like David and colleagues, because that actually gave another facet, another strength to the argument.
Well, the time is going. I will introduce now. I close the panel. I thank all the people participating to very interesting debate, focusing on the different aspects of the mental health services for young people implementation. And now I will introduce Teresa Di Fianna. Teresa Di Fianna is a psychologist. She is a senior officer of the Ministry of Health, Italian Ministry of Health, and she leads the mental health unit in the ministry, and she is appointed as a national counterpart to WHO Europe, and is the Italian expert for the European Commission for Mental Health and Dementia.
Wow. Thank you for inviting me and giving me this opportunity to try to sum up some of the fantastic stimuli that have been given to me from your presentation and from the discussion and with the audience. The title was Looking Back and Moving Forward. Looking back means that we have a lot of years and a lot of work on the back, because many of the things that have been suggested today have been discussed for many, many years in those international contexts that Antonio was mentioning, at least for my experience. So I think that we have already done a lot of work in assessing evidence. We have a lot of evidence, and so we have to move forward, moving from evidence to action, really to action. I will pick one of the first key words that I had in my mind before coming that have been confirmed by all the people here around the room. One of the first words was promotion, that David mentioned. I think that promotion is basic in this field. We have to promote mental well-being of our young people, but of the world general population, in order to reduce the effort which is needed to work in early interventions and in mental health in general. And of course, very few amount of money is spent among the few money that is spent in the general mental health. So first message to take home, at least for the policymakers, is to try to invest more on the well-being of the world population and the promotion of well-being of the young people in a country. Which means also work a little bit more on prevention, because promotion is more general, comes before, but after that there are evidence-based prevention intervention that can be put into place in a country. And third, approaching the level of services, there is the risk assessment. Risk assessment is another important element that we have to take in mind when we think and work for early intervention. And then early detection and start with the real, the concrete work with people with the first sign of some kind of not really disease or before the disease, some kind of uneasiness in their life. And those are let's say, the things that are in the background, which are fundamental for working when we work with people with mental problems. After that, there is something that the family representative who is living right now was suggesting, the empowerment of all the actors who are really involved in this problem. First of all, the people who are feeling they don't live the fullness of their life and of their well-being, the families who are around those people, and then the larger context in which we live, which means that we have to ask all those people to be an important part of the whole process of evaluating the situation, suggesting solutions according to the needs that they have expressed, and then helping in constructing the pathways towards a kind of solution to achieve the better level or the best level possible of quality of life for those people. So empowerment is crucial. And I think I don't want to move from the general context to the Italian context. I don't know the proportion of Italian in the room. They know the situation. It's more similar to Spain than to Denmark or UK. But we are struggling to have all those people involved in the problem being the major actor of the solution that we propose. What can a government do? Promote research is first of all, but research is not enough. We have evidence, but we should have research translated into action. And to do this, I was just mentioning before what we put in our national plan. We have to create effective mechanisms to translate from research to action, but to evaluate, to monitor the implementation, evaluating it, and making what is necessary to change to better achieve our goals. So this is one thing that a government, a central government, can do. And a few words on Italy. In my department in the Ministry of Health, which is the Department of Prevention, we have set up a research funding mechanism which only aims not to basic research, but to research which is immediately translated into support to the national health system, to the network of services. And this is, I think, very important because it's different from the research which is closed in the Holborn Tower, as we say. It's the research that is made in the field together with the people and all the professionals which are involved, who are involved in this. Which reminds me of another key word, the network. Networking is crucial. In mental health, we need to work together with many, many other sectors outside the health sector. And since we are, first of all, talking about youth, we have to work with the education system. Education is crucial. In that area where our young people live a large part of their days, of their life, we need to have people who are able to understand the first signs of a problem and help to lead the right pathway, to lead the person along the right pathway, to seek help as soon as possible. Education is one sector, but social sector is another one. Because I don't think that we can have solutions for our health problem without the help of our social sector, all the social powers that we have in our society. But also labor. We were talking about 14, 35 years old people. Labor sector is one crucial place where we can promote well-being, and we can do a lot to avoid the onset of more serious problems. Then I think that the general policies can help us in focusing on the problems that we can afford at regional and local level. Going back to what international associations have done, or bodies, international bodies like WHO, which was mentioned by you in your first slide, by Joe, or the European Commission, I think that we have the possibility of using what the international organizations suggest us in a more practical way. And let me give you a second example taken by the dementia field. We have been working during the last years in two European joint action on dementia and one European joint action on mental health. The first European joint action on dementia was named Alcove and was coordinated by France. The second one, which just started this year, is coordinated by the Scottish government on behalf of UK, and is very, very important as an example, because during the first joint action, we worked on scientific evidence. This time, we are working in translating those evidence in practical interventions in the countries which are involved. We have created toolboxes in the different areas. We have 4 technical work packages, and we are now implementing the toolboxes in our different countries. One of these is on friendly communities, which brings me to the final comment I think I can give. This is a matter of change of culture, of change of our communities. So we have to create friendly communities for all the most disadvantaged, vulnerable people. Fighting stigma, of course. I think we started many, many years ago, but we still have work to do here in Italy. We started in the late 70s, but we still are working with the issue of fighting stigma to change the culture and to have people recognize that full citizen in our countries. So, to close, since I think that the time is really running, I think that any of us here in this room, but here in the IEPA, have a different role. We can act this role in our different countries. We can go back right now to our work, to our country, and to bring the messages of the compelling need right now to start acting. And so I will do, as Rita was asking me, what I can at ministry level to try to focus the attention on this, because as I remembered before, it's already in our planning. It's now the time to act all together, each with its different powers. Thank you.
Thank you. As I close this session, see you tomorrow.